Multiple medication use has been coined polypharmacy. Polypharmacy is highly prevalent in older patients, secondary to the increased number of comorbid disease states associated with aging. A polypharmacologic approach for certain diseases has shown to improve therapeutic response, decrease morbidity and mortality. On the other hand, polypharmacy may induce iatrogenic complications that are often unseen prior to the initiation of medicinal regimens. Consequences of polypharmacy include adverse drug effects, drug-to-drug interactions, disease-to-drug interactions, food-to-drug interactions, nutraceutical-to-drug interactions, and medication cascade effects. Medication administration errors further complicate the issue. In 2000, it was estimated that medication-related problems caused 106,000 deaths annually at a cost of $85 billion. A 1997 study indicated that 30% of hospital admissions in elderly patients could be linked to drug-related problems or drug-toxic effects. Given the breadth of this problem, it is reasonable to discuss the issue of polypharmacy in the geriatric population. That is the purpose of this video. Polypharmacy has various definitions in the literature. Among them are any drug regimen with at least one unnecessary medication, minor polypharmacy, defined as 2 to 4 medications per drug regimen, major polypharmacy, meaning more than 5 medications per patient regimen, concurrent interacting medications, medications not indicated, drug side effects treated with other drugs, and clinical improvement following medication discontinuance. For the sake of clarity, the working definition of polypharmacy used during this discussion will be 5 or more medications taken. We will start with a review of pharmacodynamics and pharmacokinetics. Pharmacodynamics entails receptor changes at the cellular level, such as receptor upregulation, downregulation, and receptor sensitivity changes, also known as affinity. Pharmacodynamics is easily affected in the aged, not only due to the receptor changes, but also due to polypharmacy. Multiple drugs in a geriatric patient system can compete, prevent, or antagonize each other at the receptor site, which may blunt or enhance the pharmacologic effect. Pharmacokinetic parameters entail drug absorption, distribution, metabolism, and excretion. Concurrent use of multiple medications and pre-existing diseases potentially affect the pharmacokinetic parameters in older patients. For example, individuals aged 65 years and older have demonstrated a 15 to 25% decrease in serum albumin concentration compared to younger adults. Therefore, protein-bound drugs such as warfarin and digoxin will have greater physiologic effect at smaller doses in aging individuals compared with their younger counterpart. Walking the fine line between benefit and harm is difficult when managing polypharmacy in elderly patients. Literature demonstrates solid benefit in using a pharmacologic regimen in certain disease states to improve therapeutic response and improve quality of life, as well as decrease morbidity and mortality. And existing clinical guidelines recommend the use of more than one agent for the treatment of hypertension, heart failure, and post-ischemic cardiac events to decrease morbidity or mortality. On the other hand, studies have shown that potentially inappropriate medication risk is higher in elderly patients who take multiple drugs. Screening tools, such as the Beers criteria, have been developed to assist physicians in identifying potential adverse drug interactions. But there are few validated quality indicators that exist for prescribing in general practice, and published standards tend to be consensus-based rather than evidence-based. Thus, the problem persists. The World Health Organization defines an adverse drug reaction, ADR, as a detrimental response to medication that is noxious and unintended, and which occurs at doses normally used in man for the prophylaxis, diagnosis, or therapy of disease, or for the modification of physiologic function. Polypharmacy in the elderly has consistently been associated with an increased risk for ADR. An adverse drug event, ADE, is any injury occurring during the patient's drug therapy and resulting from either appropriate care or from unsuitable or suboptimal care. ADE includes ADR and medication errors. Adverse drug reactions are typically classified in one of four areas. Drug-to-drug interactions. It is estimated that 3 to 5% of all in-hospital medication errors are due to this. Computer programs have been developed for use in institutions and home health to help identify potential problems and facilitate medication reconciliations. Clinical pharmacists can be a valuable resource to the multidisciplinary team in managing patients with complicated regimens and potential drug-to-drug interactions. Disease-to-drug interactions. These are changes in the effect of a drug caused by a pre-existing condition or disease. Examples include altered volume of drug distribution with ascites or obesities, impaired drug detoxification with hepatic cirrhosis, or compromised drug excretion with renal insufficiency. Food-to-drug interactions. The use of multiple medications increases the risk of drug-to-food interactions when a food or nutrient interferes with the action of a drug. The most common form of food-to-drug interactions is pharmacokinetic, which refers to food affecting the absorption, distribution, metabolism, or elimination of a drug. For example, food decreases the drug absorption of metformin, putting a diabetic patient at risk for impaired glucose management. Nutraceutical-to-drug interactions. Herbal remedies and dietary supplements are popular among the elderly because they are conveniently available in stores and often misunderstood by consumers to be safer than medications because they come from a natural source. Elderly patients with polypharmacy may not report to their primary care physician that they are also concurrently taking herbal products unless the physician proactively asks the patient. However, clinically significant herb-to-drug interactions can occur. An example is that anticoagulants combined with alfalfa, feverfew, or ginkgo biloba increases the risk of bleeding. Adverse drug events can also be caused by a medication cascade effect. This occurs when a drug side effect is misinterpreted as a new medical condition, leading the provider to prescribe a second drug. This unnecessary use of a second drug now compounds the medical regimen and puts the patient at risk for more side effects and potentially more drug-to-drug interactions. Therapeutic duplication is the use of two or more drugs from the same therapeutic category at the same time by the same person is more common with polypharmacy. Typically, these errors occur when there is a change in care, change in doctors, consultation from other specialties, or upon discharge from the hospital. The final category we will discuss is patient-related administration errors. Epidemiologic studies show that 6 to 24% of individuals older than 75 years of age have some degree of cognitive impairment. Understandably, a patient with dementia who is not monitored by a caregiver can make mistakes with medications pertaining to amount, dosing, and frequency. Medication management skills can deteriorate in the aged, even without dementia. The following are some common administration errors seen in elderly patients with polypharmacy. Phonetic confusion, in which two medications have similar names but entirely different effects. Flip-flopping errors, in which a person confuses the dosage or frequency between two of their current medications. Pill visual cue errors. Older patients use visual cues to identify their meds and relate them to their diseases. When a generic is substituted for a brand name, or when a new medication is introduced which looks similar to a current med, confusion can result. Medication non-adherence, which is common among the elderly, has a potential for treatment failure, disease progression, and adverse drug events. Medication adherence rates in the community-dwelling elderly has been reported to vary in a range of 43 to 95%. Medication adherence is a complex behavior that involves drug-related factors, number of drugs, adverse effects, dose regimens, as well as the psychosocial profile of a patient, cognitive ability, health beliefs, social support. Interventions to assess and improve medication adherence in the elderly may include telephone call reminders, written information provided to the patient, medication organizers or charts, memory aids, color-coded medication schedules, verbal teaching, voice-activated message dispenser, and programmable electronic pill dispensers. Numerous factors contribute to the high prevalence of complicated medicinal regimens in the elderly. Risk factors include multiple specialties with minimal coordination of care, multiple pharmacies filling prescriptions, multiple over-the-counter medications, and herbal supplements which are not regularly reviewed. Numerous hospital visits, automatic prescription refill, provider propensity to prescribe medications during clinic visits, and patient tendency to borrow medications from others. Our role as physical therapists has been gradually but steadily shifting to an increased emphasis on active participation in medication reconciliation for our patients in all settings. Hopefully our talk has helped you to understand the importance of this new challenge within our profession.